Well, thank you very much, everybody. Thank you very much to the board members and scientific advisory board members of the Jung Foundation. It's an honor to be here. I'm very humbled to be able to talk to you today about a topic that's really at the intersection of technology and clinical care. And I'm trying to give you a bit of an overview of how AI is already starting to help us make better decisions in oncologic surgery. And I'm going to start out by framing this as part of a technological, basically timeline of surgery. So if we think about surgery 150, 200 years ago, it was bloody, it was probably not as clean as it is today. And one of the first big changes in surgery that actually made surgery possible or took it to a whole different level was the introduction of general anesthesia. And this was in 1854. About 100 years later, this is about 80 years ago now, 70 years ago now, in Boston, Joseph Murray performed the first successful kidney transplantation. And so this was another milestone that we can basically replace the organ of a diseased organ or a dysfunctional organ with a donor organ. And this was another big change. And then only about 20 years later, there was another big revolution, and this is minimally invasive surgery. I'm going to talk a bit more about minimally invasive surgery towards the end of my presentation, but this was really a massive change from the standard that was open surgery. And so in the 1970s, Kurt Sem, who you see on the left here, he was actually an instrument builder. So he was trained in making these mechanical instruments. It's a story I find totally fascinating. He basically built these instruments himself, but he was also a trained gynecologist. So he basically thought about how we can make surgery less invasive and give our patients less trauma while getting to the same pretty much the same result. And of course, this wasn't possible for every surgery in the beginning. It went through a lot of technological iterations, as you can imagine. For example, on the left, what you see here was he had just invented the head ring, which held the camera for himself, so he didn't have to hold it with one hand. So he had then two free hands to manipulate tissue under sight. And so this was totally revolutionary at the time. And he was actually banned from some professional societies. They had him take like a mental illness test because they thought like only a person who's mentally ill will come up with something like that. Back at the time, people said like big surgeons, big cuts. And this was a big transition. But only a couple decades later, it's now the standard of care, and this was only how it started. Because today, this is what it looks like. Almost every university hospital in Germany will have access to these types of robotic surgery theaters. What you see here is basically, it's called master-slave system. So what you see in the middle of this picture is the slave. So this is basically 4 arms of a robot that hold this camera and the instruments. And so basically the surgeon can manipulate with 3 arms at the same time while one arm holds the camera. I'm going to show you some high-resolution videos from that later in my presentation so you get an idea of like the advantages of that. And so the surgeon is actually not the one you see in the middle of the picture. That's also a surgeon, but this is not the surgeon who steers these arms. That surgeon sits next to the patient. They don't even wear sterile gowns. So this is really a big transition from like 1850s, where we had general anesthesia for the first time, and today where like there are small cuts, but we still do major tumor surgeries with these types of setups. So I would like to frame my talk as maybe the next step of this technological innovation. AI is transforming every aspect of our life, and I would argue every single of the 3 very diverse topics that we are talking about today and learning about today is influenced in a way by artificial intelligence and the possibilities and the opportunities it brings. One thing in surgery that has stayed the same over time is that complications are very relevant and very dreaded. And so this is what patients will think most about and be worried most about. And surgeons will also be most worried about how we can avoid these complications. And complications are very, very, very relevant. In fact, they are the third greatest contributor to death worldwide. So 4.2 million people die every year within 30 days of surgery. So there is some connection to the trauma that the surgical procedure brought. And so this is a very important topic to think about. And at the same time, it's important to understand that there are so many factors contributing to surgical complications. And in clinical surgery, we've learned about that by looking at the data of patients who developed a complication versus those who didn't develop a complication and basically compared that statistically. And we found out that there are patient-related factors like higher aged people typically tend to have a higher chance of complications, or people with a lot of comorbidities, people who have diabetes tend to have a higher likelihood of complications. At the same time, the diagnosis matters too, right? Like a higher stage tumor that requires a more invasive operation will probably also give the patient a higher likelihood of experiencing a complication. But then we also know that the technical quality of the procedure matters. It matters how often a surgeon has done the procedure before. And so this is really a fuzzy mix of different components. And this is what my research is about, to better understand this mix of the different components and figure out which components we can alter to improve outcomes for patients. And so this is a pathway that stretches from basic research about understanding risk factors and better predicting outcomes to even conceptualizing quality improvement interventions. And I'm trying over the course of this presentation to give you a bit of a peek into different areas here. And so what's important to understand is these patient and diagnosis related factors, they are easy to quantify, right? Age is trivial to quantify. You either have or have not a comorbidity, but these are typically non-modifiable. You can't change that. The procedure, however, that's very challenging to quantify, right? Like, how do you tell apart a surgeon's skill or the technical quality of a procedure? And how do you modify that then? At the same time, we know that we can train, right? And if we give surgeons feedback and tell them to do something different, this is the component of the care pathway that we can actually change. We can choose to do open surgery versus a minimally invasive approach. And this is just one example. And it all influences outcomes. So I will give you two examples from areas of research that my team looks into. The first one is for preoperative risk prediction and preoperative risk stratification, if you will. And the second one is about intraoperative analysis of video data. And so let's start with the preoperative decision support part. I'll use pancreatic surgery as an example in a very recent project that one of my graduate researchers is working on right now. And the leading question here was, can we estimate the risk of incomplete tumor resection before we even start the procedure? So can we understand, is this a patient where we have a high likelihood, a good chance of removing the entire tumor, which is very important in pancreatic cancer, or is this a patient who's at risk of having remaining tumor? And so pancreatic surgery, I'm just going to give a very quick introduction to give you an idea of what we're looking at. So on the left, you see the pancreas, and in a pancreatic head resection, the reconstruction of the anatomy will be very, very complex. So there's 3 different anastomoses, so suture connections to build during that surgical procedure. And there's a lot of blood vessels in the area, and these blood vessels are critically important for outcomes. And so arterial and venous involvement in pancreatic cancer really defines resectability. If the tumor is too close to the artery, that will mean that the tumor is much harder, much more challenging to resect and resect entirely. And vascular reconstruction is a key challenge in these borderline resectable cases that we still try to cure. And at the same time, complete resection of the tumor and lymph nodes is critical for survival. A pancreatic cancer patient currently cannot survive if the tumor is incompletely resected. So this is a key outcome to look into. So what did we do? We took the preoperative CT images from about 300 patients undergoing curative intent surgery at Indiana University School of Medicine. And we used an AI model trained on 9,000 CT images to reconstruct the vascular anatomy. And you see 4 cases here. So you basically see what we got from these CT images. You will see the pancreas in the middle in yellow, brown, and green. And then you will see the vascular anatomy in red, the arterial anatomy, in blue, the venous anatomy. And we also could segment the tumor. So the tumor is basically the orange part in these images. And so from these images, we then reconstructed, basically we segmented these anatomical structures from the CT in a 3D shape. And then we basically calculated the proximity of the tumor to these venous and arterial structures. And this then gave us different components that we could automatically quantify without any human input from these preoperative CT images. Now, what did we see? We saw that these segmentation-derived anatomic relations, so the proximity of the tumor to the arteries and the veins, that these are significantly different between patients that will have an R0 resection, so a complete tumor removal, and an R1 resection, so an incomplete tumor removal. And we found out that this is actually a signal. So this doesn't seem to be random, and this was what we expected too. Then next, so basically as a bottom line for this step of the process, we found a method to automatically characterize these spatial relationships that right now surgeons understand by looking at CT slices. So right now the standard is basically you would scroll through an axial CT, for example, and try to reconstruct it in your brain and try to understand this arterial involvement, and radiologists would interpret that as well and help you understand it. But this is really an automatic way to characterize these relationships. We then trained AI models, not just based on these spatial relationships, but also on the preoperative CT. So we used radiomic features, basically mathematical features extracted from the image about, for example, grayscale features or histogram features and volume features and so on. And then we basically merged that also with clinical data that are available before the procedure. I'm talking about tumor markers, for example, anything we know about the patient. This includes also age, this includes sex, this includes comorbidities like diabetes. And what we found was that we can actually predict to a degree. It's not a perfect prediction because, again, it's a fuzzy outcome to a degree, but we can understand the risk factors deeper with this artificial intelligence-based modeling. And we basically identified also that there's a higher likelihood of an incomplete resection in patients who did not receive neoadjuvant treatment, so who underwent primary resection. Those who underwent pancreaticoduodenectomy, which is pancreatic head resection, versus tail resection, which might be because of a higher likelihood of vascular involvement that's actually very challenging anatomically, and those with low arterial tumor clearance. And so we also checked for biases of our prediction model. That's a very important component for AI prediction models in medicine as well, to understand, do they work better on male or female patients? Like, do they bias against specific patient cohorts? And we found that there's a stable predictive performance across patient populations. So as a bottom line to this part of my presentation, this is an example for a project that tells us like a few risk factors for a very, very relevant surgical outcome, which would be incomplete tumor resection. And we can, to a degree, help anticipate that. And remember, all of these patients underwent curative intent surgery. So they went into the operating theater with the surgeons and the patients anticipating that there's a chance for complete tumor removal. Now, for some patients, there might have been a chance or a better chance of complete tumor removal if they had received neoadjuvant therapy. And these are the next steps in this type of project to try and simulate what if. So what would have happened if this patient had received neoadjuvant treatment? What would have happened if we would have sort of flipped around the treatment a bit? And so there is a lot of downstream projects to this. I just wanted to give this to give you an idea of how we use the different data that we have available to try and predict oncologic treatment outcomes in surgery. Now let's move on to a different topic. Think about minimally invasive surgery, so the images of the surgical techniques, the head ring, and like all of that, and the robotic surgery. How can we measure operative quality from video? And I would like to give you an idea of why this matters, or why we look at this. We look at this because we know that what happens in the operating room really matters. And so what you see, these are data that are 23 years old now, landmark publication that basically identified that the more a surgeon operates, the better their outcomes are. It sounds very trivial. It sounds like something everybody should know. But at the same time, seeing the numbers so clearly in front of you really strikes me every time I talk about it and think about it. And so what you see is that there is a strong association between the volume of patients that a surgeon operates on and these outcomes like mortality even, so death of patients in the post-operative course. And this is particularly strong in complex surgery, like esophagectomy or pancreatic resection. And now the good thing is that we have documentation today of what happens in the operating room. We have these video data, and surgeons can see these nuances between a patient who's likely to have a good outcome and a patient who's less likely to have a good outcome. So if surgeons looked at these two images side by side, they would probably see these nuances, that there is some blue tint in the right picture, right at the suture, at the anastomosis, and that might be a hematoma. And that is typically not good for the anastomosis and has a higher risk of an anastomotic leak, and a surgeon will be able to tell that apart. And vision language models, the type of foundation models that we're all familiar with since ChatGPT and the successor models of those, are getting better and better at understanding these nuances, but sometimes they need a little bit of help still. So surgical video, other than, for example, radiological imaging, has been one of the very challenging data types for these types of models to interpret. And so I promised to show you a bit of video data, video footage, to just show you what these video data look like. So this is a video from a robotic hemicolectomy for a colon cancer. So the patient had a neoadjuvant immunotherapy for their colon cancer. And so this is what you see in the operating theater. So you see that there's 3 arms that one surgeon coordinates here, and you get a really, really high resolution image during that operation. You can really see these tissue planes that are separated. And so this is really very convenient for the surgeon to operate. And you can imagine that this is a really high quality signal for us to understand what goes on, or what's going on in the operating theater, and that perhaps this signal, if merged with other patient data, could help us predict complication risks or better understand complication risks, and downstream perhaps also infer what we could do differently to reduce complication risks and improve the chance of a positive desired outcome. Okay, so at the same time, I now talked about the vision and where we want to get, and like this is all of basically my research agenda for the next couple of years. The question that I'm asking myself in my ongoing research is, can AI models decipher these nuances of technical quality from surgical videos? And so we first wanted to get an idea of the state of the art. And so we did a systematic review of the landscape of surgical scene understanding research. So surgical scene understanding is research on understanding these surgical scenes with AI. It's very, very simply put. So understanding what's going on, which anatomy you see, which instruments you see, and so on. So we looked at what are people actually looking at? And we found that it's actually very simple research. So between 2010 and 2024, instruments were the primary detection targets. What does that mean? People looked at where in an image is an instrument located. Also, most of the research was on laparoscopic cholecystectomy, gallbladder removal, gallbladder surgery. This is a relatively simple type of surgery. This is not the type of complex tumor surgery that I talked about before. This is not pancreatic surgery. This is a surgery type, however, that's very common. There's a lot of video data for it, and there's very few complications. So also surgeons feel more comfortable sharing it with the research community because there's few things that can go wrong in this type of surgery. And also, most of the AI training was supervised. So this is a more simple type of training for AI models. And so basically also, we looked then at like what target areas does this research address? And we found that this surgical video AI research is really disconnected from clinical needs in a way that most of it is really, really descriptive. I already mentioned that people looked into like where are tools located, which is probably not that insightful for surgeons. And very, very few studies actually look at prognostic factors, which would be like who is at a higher likelihood of complications or who's at a higher likelihood of adverse outcomes, or prescriptive. So actually this real-time assistance in the operating room, that's very, very rare. And so overall, what we identified is that there has been in surgical AI research a really strong disconnect between these patient and diagnosis related variables that I talked about in the first part of my presentation. So like the preoperative CT images and age and sex and these variables, and then this video research. So the videos have been looked at in isolation pretty much. Oftentimes we don't even know for a given video in a public data set, was it a male or a female patient, or was it an old or a young patient? And so all of this is really, really important to connect because these data belong together. It's from one patient. And so we got to look at this in a more thorough and comprehensive way. And so right now, my research goal is to understand the root causes of surgical outcomes with AI-based multimodal causal modeling. And this is also what the Jung Foundation supports me for. And so we will be looking at combined dimensions of care. And so we are looking at patient-derived variables, diagnosis-related variables, and procedure-related variables, trying to actually connect all of these to better understand these outcomes, and then mechanistically model those outcomes. What will be the impact of all of that? Why are we doing it? So on the one hand, we could derive targeted quality improvement measures. So what can we do better in the operating room to reduce the risk of outcomes? Is it tissue tension? Is it something we already know and have an idea of? Or is there maybe some hidden patterns that we aren't even aware of in surgical training yet and that we could do better relatively easily by training them? We could also look into personalized surgical treatment. And this was already what I alluded to in the first part of my presentation. This would basically consider all preoperative variables. But of course, there's also post-procedure care and follow-up. So we could also think about after the procedure, now that we've seen the video, now that we know everything about the patient that we know at that time point, does this patient have to be on an intensive care unit for follow-up? How many days will the patient have to stay in the hospital? And all of these post-procedure care questions. Okay, and so I'll keep the conclusion really short. What we have right now is we basically combine preoperative variables and the imaging sometimes, and we can understand complication risks. We can understand resectability to a degree. What we want, though, is something actionable for surgeons. We want to understand, like, what can we do differently to improve outcomes? We want to understand which margin is at risk for incomplete resection. Where should we really watch out during the procedure? Should we change the approach? Should we do open surgery versus minimally invasive because we wouldn't be able to do the procedure minimally invasively? And what is the risk of tumor recurrence? Can we anticipate that before it happens and take better care of our patients? And so I'm really humbled and honored that the Jung Foundation is supporting me with that transition. And I'm also very grateful for a fantastic team at Purdue University in the US and in Dresden. And I look forward to your questions. Thank you for your attention.